Dr. Partha is busy with his some other work. So he was supposed to cover phaco in the post-refractive surgery patients. So I'm going to show you one video because we do have a lot of patients with post-RK. And one of the major consideration is getting a good biometry done in these cases and a good IOL power calculation. So which will be the best IOL formula calculation for post-RK patient? I would ask Dr. Manpreet to answer this. What should be the best way to calculate IOL power in post-RK and post-LASIK patients?
So post-RK, post-LASIK, both will be associated with central flattening. So the aim is not to rely on the conventional keratometers because the anterior to posterior corneal curvature ratio is altered. So any of the newer generation formula, Barrett Universal, which is based on the IL Master 700 Feft source OCT, and then using Barrett Universal, which takes into account both the anterior and posterior corneal curvature, works well. Haig's L for myopic LASIK and Haig's hyperopic for hyperopic LASIK work well as well.
Okay, thank you. Subin, which formula do you use for post-RK patients?
If I could get access to the Barrett suit, I would use that. And more importantly, it's measuring the corneal curvature, because most of our devices are measuring the anterior curvature. So if you have a OCT-based one, which is measuring the posterior one, also like the Zeiss 700, which measures the TK.
Okay.
With the telecentric.
Shall?
So for post LASIK now, most of the formulas designed for it work quite well. So Barrett True K would be my choice. But for post RK, it is still very variable depending on the number and type of cut. So I would still go to the ASCRS calculator for post RK. And amongst the three, minimum, maximum, and average, I will choose the average and maybe choose half diopter or more stronger power than that.
Absolutely correct.
Post-RKs are going to linger on for some time, and even few months probably, because of the corneal edema.
So what we understand, post-RK and post-LASIK patient, they are different. Like though they come under the refractive surgery category, the IOL power calculation in post-LASIK patients are now not difficult because we have a newer generation formulas which covers everything, and you have a very nice predictable outcome in these cases. But post-RK is still a challenging cases. So we might pick up the 2-3 formulas, especially the corneal power calculation has to be nicely done. So if you 2-3 devices, always take the corneal power which is flatter amongst all three, and you calculate the IOL power from 2-3 formulas. Take the highest power available in amongst the three formulas. So flattest cornea from various devices and highest power from the various calculations. If you go by that, most of the time you will be accurate in these cases. But if your corneal profile is better, aberrations are not there, then you can go for a sometimes premium IOL if your incisions are less than 6. But toric IOLs can be done in these cases because it will be helpful in some cases. Like this is the patient has more than 12 incisions. Your incision has to be between the two incisions, and it should be little scleral incisions. Otherwise, the incision can open up. And rexes should be done in a manner which is as desirable. Around 5 millimeter rexes is desirable for all toric cases. In fact, all IOLs. In RK patients, sometimes you may have a incision causing scarring and deformity coming, and you can inject the little bit over the cornea, put a viscoelastic that gives you better clarity also. Good hydro procedure required in these patients because nucleus will be little harder in all myopic patients. And soft cell technique always safeguards the endothelium because all post-refractive patients, the endothelium may be compromised. It is always better to do a soft cell technique. The nucleotomy can be safer because the bag is normally intact in these patients. Rotate the nucleus, make a multiple chops. That is always important. Whenever you are doing a chop technique, it's always better to do a multiple chop in the intact bag. If you remove one chunk of a nucleus, then subsequent chopping can be difficult sometimes. So this is a flipping technique of a nucleus where you can emulsify subsequently without any difficulty, especially in a harder cataracts. Flip does work in a separation of a multiple pieces here. Other important thing is remove the cortical fibers and epicortex safely, and this will decrease the opacification both for anterior capsular margins as well as posterior capsule also. Inject viscoelastic. Now we'll inject the IOL. Normally, toric IOLs should be desirable in all cases, but if in those cases where a lot of aberration, like higher order aberration, then patient may not benefit with toric IOL as such, but it will definitely decrease the load of a power in a patient, because patient has more than 2 diopter cylinder. Better to put a toric IOLs. So this is a Technis toric IOL with a new modification, which has a very nice fixation in the back. You can see I don't hydrate the main wound here. I'll put a suture, because if you hydrate the main wound, you're going to separate the incisions, and things will be very difficult. So we did 2 or 3 things which were very classically taught for our cases with RK is the main incision should be between the 2 incisions if possible. If your incisions are at least 30 degree apart, you can do it. And always do a little posterior incision. If possible, you can make a flap also and do a scleral incision so that you safeguard the incision opening. Most of the RK incision we should do almost 90% depth, and sometimes they extend the limbus also. So that precaution you have to take. End of surgery also, the wound management has to be done very effectively. Don't hydrate the main wound. Put a suture here, and you can use the hydration on the side port, which is a very small incision, and maintain the integrity of bag. And in the post-op period, make sure you manage the patient appropriately in terms of counseling. Sometimes large incisions, multiple incisions, cornea may be little unstable in the first few weeks. If patient vision is not very, very up to the mark, and wait for at least 2-3 weeks to cornea to stabilize, the wound to stabilize, then take a decision on doing a refraction in these patients. Any comments apart from this, Subin?
I think, like sir correctly mentioned, if you have a regular topography in the central mesopic pupil of the patient, so if the mesopic pupil of the patient is say 3 millimeters, 3.5, which is common in our population, our mesopic pupils are not very large, and if in that mesopic pupil zone you have regular astigmatism bow tie, those are the cases where you can definitely consider for toric, even if it is post RK or post LASIK. But like sir correctly mentioned, that be careful in choosing the first few initial cases, because the surgery itself may lead to a couple of RK incisions opening, suturing, and then the astigmatism will probably go for a toss. And I think even if there is a gap between the 2 incisions, always better to take a slightly scleral incision, because we never know what maneuvers may lead to a split in the incisions.
Thank you. Any other comments?